Hey everybody, it's Stephanie Courtney from the Learning Project. You guys, I am so excited today. I have a very special guest, Dr. Danielle Lane. I want to welcome you so much to our newest segment called Sending Strength and Love. You guys, we are sending you all the positive vibes today. I am so excited. We've been going through a lot of different series talking about infertility, pregnancy, adoption, surrogacy. We're talking about it all because this is a part of everyone's life. There's not one way to have a family, and everyone's story doesn't look the same. And so I want to bring stories that really resonate to individuals and really help them to understand what people's journey look like. And so, Dr. Danielle Lane, thank you so much for being here. I am so excited for today. We are going to be really going through different tips about when you're going through the process of infertility. What does it look like? What should you do? What steps should you take? Anybody who knows my story, it was all over the place, right? I tell you guys from the very beginning, I was just jumping from place to place to place. You read an article, you're jumping on whatever they say. Dr. Danielle Lane is going to give us some great tips today and advice, and we're going to learn so much from her. So thank you so much for being here.
Thank you for having me. Excited to be here and really excited to provide information. I'm very passionate about that. So thanks for having me.
Thank you, thank you, thank you. So tell me, Dr. Lane, why are you passionate about women's health, and what got you into this field?
Well, it's funny. When I started residency, I thought I was going to save the world and help everybody who was having teen pregnancies that didn't want them to find ways to contracept. And then I realized that the world didn't necessarily need saving on that front, and that contraception was all over the place. And that the reason that women were having kids as teenagers was not from a lack of contraception, but from a lack of a whole bunch of social issues that were impacting that. And I thought, okay, maybe that's not really what I want to do. So then I started to think about, who I was going to be as a woman. And I realized that what I was going to spend my life doing was balancing my career with my family. And that brought to the forefront for me the whole topic of family planning, but not family planning in the idea that we should contracept, which is how we talk about it in the United States, but family planning from the perspective of actually planning to have a family. Like, what does that look like? How do we think about when we want to have our kids? How do we protect and make sure that we're going to be able to have our kids when we want to have them? And so that sort of drove me down the path of fertility, and I've been doing that work ever since. I think what I find to be a long-term goal, I'll say, let's spin it to the positive. A long-term goal would be to really see that we are improving in how we educate ourselves and our patients and women as a whole about our bodies and about our reproduction, right? We just don't know. We don't know about our menstrual cycles. We don't know about what it means to try and get pregnant. We don't know what's normal. We don't know what's abnormal. And so when we are finding that there's a challenge in trying to conceive, we really are at a loss and we don't know how to move forward. And I think we can do better than that, right? You know, in addition to that, as you and I have briefly talked about, there are all these barriers for some patients that are different than others. And so I think that in addition to the fact that we need to just generally educate, we need to really make sure that there's cultural competency amongst all of the diversity around this topic, because we, as a field, and really as a society, have failed on that front. We can do better than that.
I love your passion for this area. And, so many times when we're talking about family planning, we're talking about creating a family, we run into different roadblocks. And infertility is one that many women face. It's like 1 in 4 women actually will face some form of infertility. So this is something that's really common. And you kind of get into this habit where you go onto Facebook and you get Facebook knowledge and you get Instagram knowledge. And you're yes, Google knowledge.
Yeah,
Google is nothing like Google to scare the mess out of you.
That's true.
And so, you are trying to get this knowledge, you're trying to figure out what to do. So if someone is having symptoms, I guess we should say this, what are the first common symptoms of infertility that people typically may not see
I would
or
even
even
go,
they overlook?
I would go a step back and say, what's normal, right? Because in order to know what's abnormal, you've got to first know what's normal, right?
Yeah.
So, we used to talk in the OR about, still talk in the OR, return things to normal anatomy. Okay. So
Yeah.
if you talk about what a normal reproductive cycle is, you should be having a period every 25 to 35 days, and it should be relatively regular. It may not be 31 days every month. Maybe some days it's 32, some days it's 28. That's okay. But it shouldn't be, every 20 days, and it shouldn't be every 60 days, right? That's not
Mhm.
normal. So normal cycles, 25 to 35 days. Then based on age, okay, if you are under the age of 35, the recommendation is that, and then there's the recommendation is that unless you know that there's something wrong, because then this doesn't apply, right? And that's sort of
Mhm.
where I stuttered there. You know, you should expect it to take up to a year of unprotected intercourse to conceive. So if you're under 35 and you've been having unprotected intercourse for a year, not that you've been trying or doing ovulation predictor kits or
Mhm.
timing
Mhm.
out your basal body temperature and your luteal phase, but that you've been having unprotected intercourse for a year,
Yeah.
then you are in a good position to start thinking about a fertility evaluation, because that is outside the box of quote unquote quote normal.
Mhm.
If you're over the age of 35, right, and I'm going to put an endpoint of about 40 on that, then at 6 months of not conceiving, it is appropriate to go in and start asking for a fertility evaluation.
Mm.
And if you're age 40 and you know you want a family, just start there. Start
Yeah.
with understanding what your fertility is. So those are some of the normal timelines that we think are really important for folks to know, because if you don't know that, then you end up years and years into this. And by the time you walk into someone's office, we're like, oh my goodness, right? And so
Yeah.
then we're just, everybody's more stressed than is necessary. So that's the norm. So what are the sorts of things that might trigger you to do something sooner? So an obvious one is tubal damage. If you've had chlamydia or gonorrhea or some surgery near your fallopian tubes, you should consider going in earlier, because if your tubes are blocked, waiting for a year of unprotected intercourse is a waste of your time, right?
Mm.
If you know you're not having normal periods, or that you don't ovulate, or somebody told you a long time ago that you're going to have a difficult time getting pregnant, don't wait a year. Go in and get an evaluation and see what's going on, right?
Mhm.
If your partner for some reason knows that he's had some issues with an inguinal hernia, a varicocele, something else around his testicles, or production of sperm, don't wait a year, right? So those are the sorts of things that I think are just the norms that we should be thinking about. Does that make
Mhm.
sense?
Yes, that is like really, really good.
Yeah.
And for those that, are listening in and they're like, you know what, this information is so good. I am already hooked. Share this podcast right now. If you know someone that needs it, you guys know me. I always tell you, don't give people candy, don't give them flowers, don't give them cards, give them a podcast, give them something that will feed their mind, their soul, and their spirit. And I think Dr. Lane, what you just said, that is huge, because I even talked about this in my last podcast, where as a teen, I would have inconsistent periods. I would have painful periods. And then sometimes I wouldn't even have my period at all. And I just thought it was because I was an athlete. That's what my mom always said, you're an athlete, so that's the reason why, you're not having your cycles. And that's why your periods are so painful. And I remember like having these painful periods all the way up until about 25, 26 years
Mhm.
old, where I would even have like nausea, headaches, or I would only have my cycle for like 1 or 2 days. And so my cycle would come a lot sooner. And it was just an interesting, when you're talking about this, sometimes we're looking over things because we think they're normal, but you're exactly right. We need to find out what is normal so that we can actually compare it to what we are actually experiencing.
And menarche, which is your first period through the first couple of years, right? So maybe 2 years in, it's
Mhm.
okay to have a little bit of irregularity in your cycles. But
Oh,
after
good.
that, it should really start to regulate out, right? So certainly by the time most of us are heading from high school into college or into our first jobs or what have you, we should
Mhm.
be having regular periods. In your 20s and 30s, you should be having regular periods, right?
Yeah.
So use that as a little bit of a guide. So if you then are finding that you're not fitting into these, general demographic norms that I'm describing,
Mhm.
okay, then it is time to think about getting an evaluation. So I think the next thing that's important to understand is that there are obstetrician gynecologists and
Mhm.
there are reproductive endocrinology and fertility specialists. Okay.
Okay.
Obstetrician and gynecologists have done medical school and 4 years of training in residency in general obstetrics and gynecology, and they are outstanding at what they do, but they are not subspecialists in any of the fields of OBGYN, which include
Mm.
high risk obstetricians. Okay, that's a subspecialty. Gynecologic oncology is a subspecialty. Urogynecology is a subspecialty. Minimally invasive surgery is a subspecialty. There is a contraceptive subspecialty, and there is a
Mm.
fertility subspecialty. And
Okay.
so the point is, if you are needing fertility help specifically, there is nothing wrong with going to your obstetrician gynecologist if you have a relationship with them, if you're looking for a referral from them. But
Mhm.
understand that they should not be your guide for your fertility care, because that is not what
Mm.
they do. Okay.
Okay.
And there are certainly times when OBGYNs will be involved in the initial workup. They may even offer you an oral medication. But
Yeah.
the way in which they treat a fertility cycle is going to be very different than the way in which a fertility specialist treats them. Your
Hmm.
OBGYN is set up to see you once a year, maybe 2 or 3 times if you have a cyst or some bleeding or
Yeah.
an infection. Your fertility specialist is set up to see you as needed multiple times a cycle within the cycle to ensure that we're not missing things, right?
Right.
And so I think what's important to understand is that for most people, there isn't a barrier to you going to see a fertility specialist.
Mhm.
So
Mhm.
people will tell me, oh, well, I thought I had to get a referral. Oh, I didn't think I could come. Oh, I didn't think
Mm.
my insurance is going to pay for it. Now that's true. Your insurance may not pay for it, right?
Yeah.
But your insurance may not pay for it, period, because the lion's share of folks that are in the American healthcare system do not have fertility coverage. Like that's just the normative.
Why is
So,
that?
because fertility is not considered to be an essential aspect of health. We can
Wow.
debate that, and I'm happy to have that debate, but the reality is that's the fact. So, and I'm going to say something that I don't like the way it sounds, but it is a fact. You do not die if you can't have a baby.
Yeah.
And
Yeah.
so as a result, it's been easy for the healthcare system to sideline fertility benefits, right? And
Yeah.
not make it a priority when we're trying to make sure that, people have, I don't know, obstetrical care and flu shots and,
Mhm.
birth control and all these other things. And so there's a lot of societal downsides to that mindset, but in our society, that is the fact. So as a result, one of the things that folks need to understand is that you may have to invest in your healthcare, um, both time and resource wise, to get the care that
Mhm.
you need. And the other thing I'll say is the longer you wait to make that investment, the more expensive it will be for you, because
Mm.
you will always have an easier time conceiving at a younger age than you will at an older age. So the
Mhm.
longer you delay, the more challenging it becomes to actually get through that fertility treatment to get to the outcome that you're looking for. So I think
Wow.
that's why it's really important for me that women know what are the norms, when to go seek care, and that they don't need to ask permission to go seek care. Just do it,
Mm.
right? In the words of Nike, just do it.
Yeah.
You know what I
Oh,
mean?
I love
Yeah.
that. A lot of times when I even think about my journey and you're talking, I literally think about needing that permission to go and get help. And
Mhm.
especially when you're like younger, I think for me, you get in this habit where you feel like you need permission to do everything, right? And then
Right.
you get your 20s and you don't need permission to do anything. So you're like almost exercising this new brain and
Right.
these new habits and these new concepts for some people.
Mhm.
And I remember it was so hard for me to petition for my health. And it was so hard for me to talk about my body, about what I was experiencing, what was going on with it.
Right.
I knew something was wrong, but I just didn't think anything of it, because I was just like, this is normal. All women have this stuff. All women have these problems. I just kind of chopped it up to that. But when I would get in that, OB doctor and I was talking with them about, they're like, how are you doing? Instead of me saying, hey, I have some really painful periods and I have a lot of migraine headaches. Why is that? Like, tell me, what can I do? I would just be like, oh, everything is fine. and everything's good and I feel great and I'm healthy and happy, but deep down I knew like you actually probably should have talked to them about that
Yes.
because this is your body, and it's something that you have to learn as you get older. And hopefully the next generation of girls growing up, they'll know how to petition for their body a lot sooner and be more open about what they need and what's going on with them.
Absolutely. So if we talk a little bit about periods, they should be about, 4 to 6 or 7 days. Okay. Really, you bleed less, not very much. You shouldn't be filling a pad within 30 minutes. Okay.
Hmm.
Um, and, you shouldn't be disabled by your period. If you are spending a day in bed or 2 days in bed because of your menstrual cycles, that's not normal, right? Um,
Mm.
there are some things that I think we've gotten better at talking about, like endometriosis,
Yeah.
right? But for a long time, women have struggled with really uncomfortable symptoms, debilitating symptoms that are
Mm.
worsening without really describing that to their physicians. So, yeah, you've got to talk about these things because things like endometriosis can be impacting your fertility down the road. And if you know you've got it or you're talking about it, there are things that we can do to help decrease the rate of attrition or the decline in your fertility, right? That
Yeah.
we can't do if we're catching it on the back end.
Wow.
Yeah.
Wow. So what are the first steps? Like if a person is like, you know what, my cycles are off, maybe I've been trying for over a year now. What are the first steps that a person should take to really take control of the infertility and get some answers for it?
Yeah. So I would say the very first thing to do is understand your benefits. So we as young women and men are generally healthy, so we don't have to use our healthcare benefits. So the number of people that I talk to that really don't even know whether they have benefits to cover fertility or not, like,
Hmm.
I'll tell you where there's the exception to that is in the Bay Area, where everybody knows what their benefits are, right? And everybody knows what their companies are covering, but that's not the norm around the world. So like, get your insurance card out, call your healthcare, provider, or call your HR and
Hmm.
understand whether you have coverage for fertility diagnosis and treatment, which means the workup, or actually treatment cycles, which is different than diagnosis and treatment, right? But actually
Mm.
treatment cycles, like if you need something, is your intrauterine insemination covered? Is your in vitro fertilization covered, right? So start with understanding what you've got to work with, because that can also decrease your fear around wanting to go in and being
Yeah.
afraid you're going to have all these huge expenditures. Then, again, if you have a relationship with your OBGYN and you want to start there by saying, gosh, I have some concerns, what do you think? I would never discourage anyone from doing that, right? And even if you have a
Hmm.
primary care person, maybe you don't have an OBGYN, maybe you have just a primary care person that's an internal medicine or family practice person, whatever, go there. But here's the thing, if you're not getting the answers that you need, meaning people are not able to tell you what they think the concern is or not able to do a complete workup, which means blood work and ultrasound for the woman, semen
Hmm.
analysis for the man. Okay.
Hmm.
If we're not able to get and a look at your fallopian tubes, if your OBGYN can't do that for you or your PCP can't do that for you, then move on and find a fertility specialist to do it. Like anything else, there's always the possibility that the first person you meet may not be the person that you want to work with. And that's
Yeah.
okay. But
Yeah.
don't not go to somebody out of fear that you haven't found the right person. And I hate to say it, we're going to all have to learn to be a little bit resilient to the fact that, not every relationship is going to be a perfect match. So,
Yeah.
the consequence of that is I want people not to feel like they have to stop because they've been so damaged by whatever that first interaction was. And this is
Yeah.
not to excuse the interaction, but it's to say that don't let that be the next barrier to you getting the help and the care that you need. Does that make sense?
Hmm. Absolutely, absolutely. I mean, I remember when I first started my process in understanding infertility, and I went to my OB, and I didn't have a great relationship with my OB. And
Mhm.
you know, instead of saying, "Hey, let's get you to a fertility specialist," or let's talk about doing some blood work to figure out maybe there's certain levels in your body that are low. We went straight to you can go do an adoption, you can do get an egg donor. And it was such a shock for me. And
Yeah.
it like traumatized me. And it really, I really like, I was already struggling with our relationship as patient and
Physician.
physician. And I just, at that moment, I was just like, I can't even listen to anything she's saying because she's not even trying to take this journey with me. She
Right.
is literally just like, chop, and this is what it is. And some people are like that, and some people like that. But at that moment, I was so surprised that we were talking about infertility. And I'm like, me? Like, how am I like having infertility issues, you know?
And the other thing is that, so let me just put it out there. Anybody can have infertility issues. Okay. So
Mm,
don't think that it isn't you. You can have infertility issues, whoever you are. But I think what's concerning to me about what I just heard is I heard somebody give some recommendations that may have been slightly out of their scope of practice. So, I get a lot of questions on social media these days, and there's some of them that I just simply say to people, I'm like, look, I'm not going to do a video about that because I don't take care of that. Like, I
yeah,
just don't take care of postpartum, urinary leakage. Like, that's just not my thing. I
yeah,
don't ever see it. I don't know what the current recommendations are about it. I'm not going to comment on it. Right.
yeah.
So I think that people need to, again, be really clear on the fact that there's a difference between getting a fertility recommendation from an obstetrician gynecologist and a fertility recommendation from a fertility specialist. And you need to go the extra step, go the extra mile, and make sure that you're getting recommendations that are appropriate for you from the person who should be giving them, right?
I love it.
Don't go
Yeah,
beat up on your OBGYN if you're asking them to do something that's slightly outside their scope of practice, right? I
yeah.
think the other thing is, and I see this happen really at all levels, but we need to do a better job of listening to our patients and thinking outside of the box. And what
Mm,
I specifically mean by that is, there are going to be times when very young women can come in to see this. And I think, to your point, this is one of the ways in which you got sort of tripped up. And the assumption is that, oh, she's young, she'll figure it out, she'll get there, right?
mm-hmm.
There are young women who are not going to get there unless we do something. And so until you've worked
Absolutely.
them up thoroughly, you can't make that statement. And
Yep.
if they fall into the criteria of it's been a year, I don't care if they're 21. You have to take that seriously.
Yeah.
And so that means, as a patient, you've got to advocate for yourself too, right?
Yeah. Yeah. I this is so good. I'm just loving this because like now, like when I'm thinking about my journey, and I know a lot of you guys are out there probably thinking about your journey too. No one ever told me that this doctor shouldn't, or this doctor may not have all the information. You need to go to a specific doctor to go to these to get what you need and really understand what's going on with your body. What's the next tip that you have? So now this person has gone through this process. So what's the next step?
Well, so now they've had a fertility evaluation, okay? And again, that's blood work and ultrasound evaluation of the fallopian tubes in the female. It's a semen analysis at a minimum in the male, okay?
Mm-hmm.
And everything is normal. And
Mm-hmm.
that means that means that someone's actually taken the time to go through those results with you and explain to you, well, this was what your AMH level was. This is what your antral follicle count was. Here are the parameters in your semen analysis. And now you need a treatment plan, right? So
Mm-hmm.
the treatment plan shouldn't just be go back and try again, right? So what I'm finding sometimes is that folks come up with, and I'm speaking now really about unexplained infertility. Obviously, if something comes up, we should be treating that thing that has come up. But in the event
Absolutely.
of someone that's got unexplained infertility and things are looking kind of normal, that still means that there's a treatment plan. The treatment plan isn't just go back and have more sex. The
Mm-hmm.
treatment plan needs to be, if you want to try on your own, let's come up with a timeline for that,
Yeah.
followed by the following steps, right? And most of the time, that's going to start with an oral medication and intrauterine insemination. And those two things
Mhm.
should be partnered together, because unless you have male factor, doing an IUI alone will not improve your outcomes. Okay. And
Mm.
unless you're not ovulating, doing an oral medication alone will not improve your outcomes. And I think that's super important because I see this all the time. Those
Yeah.
studies have been done, and there is statistically no improvement in outcome if you do not partner both male and female treatments. So medication of some form with some form of either an IUI, or if the sperm requires it, an IVF cycle, right?
Yeah.
So I think the mistake that I'm seeing a lot happen is that women go in, they get their workup, they don't have a clear answer. And I'm going to tell you, a lot of times we don't have a clear answer. We have a gut,
Right.
we know which way we think we need to head, but you've got to try some stuff, right?
Mhm.
And
Mhm.
then they just go back into the world of trying, and they resurface a year later and we're still in the same place. And now we're wanting to be more aggressive because it's been a year later, and people are like, but wait, I haven't tried anything since except intercourse. And what you've lost in there is time, right? The
Mm,
biggest predictor of outcome is, by and large, a woman's age. So the longer you wait, the harder it gets. And we just
mm.
can't get that time back. You know what I mean?
It's so true.
Yeah.
It's so true. I mean, I think about all the steps that I've taken, and I think one of the things that's so hard is when you get to that point of guessing and you don't have a person really guiding you, you do lose a lot of time.
Yep.
And each month does become more traumatic and
Right.
more um it just impacts your mentality of like, putting all this unnecessary pressure. I remember, for those of us might be TMI, but you know how we do here on the Learning Project, we're going to get real. So, there's always this joke about, that time when you ovulate, how you're like, okay, we got to have sex this day. We have to do it like this. We have to go right here. I'm going to drink this. I'm going to eat this. You need to eat this. Like, my husband had got to the point where he was just like, Stephanie, we cannot do it anymore. Okay. We have literally done everything that we possibly do. I don't know what else to tell you. Like, literally, we just need to wait. But for me, I was just so like crazy. Like, every morning I took my temp to make sure, see where my temperatures were. Did I ovulate? I use an Ava band. I use, there is a little device, I cannot think of the name right now, but it's brand new. You pee on the stick and it tells you exactly where your LH numbers are. And I mean, I'm doing all this stuff, peeing on little sticks. Am I ovulating? Am I not? Like, it becomes so obsessive because you know that you're on a timeline, and you know that if you don't do everything, or if you think you don't do everything, it's not going to happen. And then you do all this stuff and then it doesn't happen anyway. And
You know,
so it was just so, when you're talking about this, like when you're talking about that time part, it is so, it becomes a real obsession. It becomes a real thing. And it becomes like almost, it basically takes over your entire life.
well, I think what I wanted to say to that is two things. One, I think part of what happens is a loss of control, and part of what
Mm,
happens is an increase in fear, right?
mm,
And the fertility, and now I'm not talking about the fertility doctors and so forth, but really the fertility world preys upon both of those things, right?
mm.
So basal body temperatures, ovulation predictor kits, like, 8 billion different fertile vitamins, like all this stuff. And I'm not going to sit here and say that there isn't any utility to any of that, but I want to go back to what I said at the beginning, which is the definition of subfertility. I'm not even going to say infertility, is 12 months of unprotected intercourse, right?
Mm.
Under
Yeah.
35, 6 months above, right? It never talks about ovulation predictor kits and basal body temperatures and that. And it's not, again, it's not that there's a problem with doing those things, but understand that what people are sinking into is this desire to need to control something and this fear that it's not going to work, as opposed to it being an effective way of actually conceiving. I am
Mm.
not going to change the fact that women are going to do that. I would be exactly like that if I was in that position. I get it. Like, I really do. I still have all the pregnancy tests that I took for every kid, and I took many of them, right? So I get all that, but it's important to recognize intellectually, if you can step back for a second, that
Yeah.
those are not the things that are making or breaking your ability to get pregnant. They're just not,
I
right?
love it. I
Okay.
love it. I'm so glad that you mentioned that, because I know so many people, like, you miss your temperature for that day, or you miss something. It's literally, it causes you to panic. It
Yeah.
causes you to cry. I remember breaking down one morning because I was so sick of doing all these steps every single morning. And I'm such a database person. Like, I love numbers. I
Yeah.
love, being able to print my little sheets out and look
Yeah.
at them. And I'm like, but you're absolutely right. It's all about that, trying to gain control, because infertility is something that you cannot control.
Right.
It's just something out of your hands. And you really have to take certain steps to figure out what you need to do. So, what's the next step, Dr. Lane?
So, so now you've been in, now you have a treatment plan, right?
Hmm.
And, and you're going to start that treatment plan, and you're going to understand the percentages that go along with the treatment plan that you've taken on, right?
Yeah.
So I think that's important too, because sometimes folks will do a series of IUIs, not be successful with them, and
Hmm.
really upset about how long it's taken
Yeah.
and really deflated about being able to move on to the next step. But they've done something that really has a very minimal success rate. That doesn't mean
Yeah.
you shouldn't try IUIs. I mean, good Lord, if you can get pregnant with an IUI and you can bypass all the rest of the stuff that we do,
Yeah.
that's fantastic, right? But
Right.
but if you don't realize that you've done something that has an 18-20% success rate compared to things that are out there that actually have a 75 to 80% success rate, and that's
Yeah.
a huge difference that people need to really take seriously. And so I think understanding what you're doing and understanding how likely it is to be successful helps you manage your own expectations so that you're
Hmm.
not deflated at every outcome.
Yeah. So one of the things that you said that's really interesting, we always talk about IUI and IVF. Like,
Mhm.
what are the other treatment plans out there that people can actually do that are in between that? Or do you really recommend people, I mean, not really, can't really recommend, but, what are those treatment plans?
So
Because
let's
I
talk
remember
about,
just hearing about IUI, IVF, that's it.
because that's all we have. I mean,
Mm.
realistically, okay,
Hmm.
what we have to help people conceive that truly have a fertility issue are increasing the number of eggs that we can release in a month to increase the chances of getting to a healthy egg faster,
Hmm.
and putting sperm closer to the egg, either
Hmm.
by putting it into the uterus and letting it swim, or by somehow making egg and sperm touch, which means either InviCell, which is the little device you can stick in your vagina, or in vitro fertilization. That's
Hmm.
all we've got right now. There
Wow.
are things we can do for ourselves that will help. So, for example, we're in California, and marijuana is all about. Stop
Hmm.
taking marijuana, and it's going to take 3 months before that's out of your system and that your sperm is improving, right?
Yeah.
Because sperm function declines with the use of marijuana, right? I
Mm.
got reamed on social media for this, but there is data that body mass index decreases will improve ovulation. So if
Yeah.
you are a polycystic ovary syndrome person and you are not ovulating, and many of our patients can track as their weight went up when their ovulation stopped, right?
Mm.
We've
Yeah.
got to get back to diet and exercise and put you in your peak physical fitness state so that you actually can, be in a position where not only are you ovulating, but when we put an embryo in, we've got a very receptive environment that isn't going to increase in terms of risk of gestational diabetes, gestational hypertension, macrosomia of the baby, things like that, right?
Yeah.
Those are some of the sorts of things that we can be helping with to improve outcomes, right?
Hmm.
Um, but in terms of actual treatments, and I mean like what we can give out as a prescription, monitor as a, as a cycle, and
Hmm.
um, and do to help improve likelihood of egg and sperm meeting, we
Yeah.
have those few things. That's it,
Wow.
right? And
Wow.
so when people are coming to you saying this is our recommendation as a first step, it often seems for people that it's a big first step, but the reality is we don't have anything else. All
Wow.
we're doing with fertility treatments really is rolling the dice and increasing the odds that you're going to win, right?
I love that you
That's what we're doing.
explain that.
Okay.
I love that you explain that, because for so long, like, I just felt like, okay, they're just pushing this on me because they don't want to dive deeper. They don't want to do this. They don't, and it kind of makes you have like this weird relationship with your doctor. And it's like, no, really, what you just said to me, no
What
one's
we've
ever
got.
said to me. Like, really, there's nothing else out there. Those are the treatment plans that most fertility specialists have. And
I mean, I don't know any that anyone else has, right? So, look,
right.
we can transplant a uterus, we can, get very technological. And in some countries, not yet in the US, we can take cytoplasm from one egg and put it into another egg and make it better. Yes, we've got surrogacy, we've got egg donation, we've got sperm donation. But really, which also means it's not a silver bullet, it's not a guarantee, because we
Yeah.
aren't changing your DNA of your eggs or changing the DNA of the sperm. We are literally just taking these things and trying to increase the likelihood that we can put more of them together in a given time frame and get you pregnant faster. Because
Wow.
what we're trying to beat is the rate of decline of your own ovarian function, right? So in
Hmm.
other words,
Hmm.
we can maybe do an IVF cycle, I'm jumping sort of to an extreme, and get
Yeah.
12 eggs, right? And make
Hmm.
12 embryos. It would take your body a year to do that. So
Hmm.
in the span of 1 month, we can achieve what your body would achieve in a year without the decline that you would have in terms of egg quality in that same year, right?
Okay.
That's
Right.
all we're trying to do with fertility treatments. Okay. And the
Wow.
reason that IVF works better is because we optimize that the egg and the sperm are going to meet. We ensure that fertilization has occurred. We are, able to biopsy an embryo and see that it's genetically normal. We can prep the uterine lining to like a specific amount, and then we can put the embryo in. And so, yeah, of course, it's going to work 78% of the time because we've done everything to make sure that that happens.
Wow.
You know what I'm saying?
Wow. Yeah, that's amazing. The way you just explained that, you guys, the way Dr. Lane just explained that. I don't know if you guys have ever heard that explanation like that, but you broke that down in such a simple way, but it helps your brain connect to
Yeah.
why the conversations are happening the way they are.
Right.
Because a lot of times when we don't have that explanation, just because we always feel like, oh, well, we could just do this, or we could just do that, or, you could do this. It's not as simple as that. And I mean, to think about the odds of what you just said and how people have done this piece of science to ensure you get further along. I mean, that was a very powerful piece.
And
Thank
that's
you
why
so
people are
much.
freezing their eggs, right? So the
Yeah.
idea behind egg freezing is that we know that your best eggs were yesterday. There's just no way
Mhm.
that, right? I mean, wherever you are in your life, your best quality eggs happened the day before. Okay.
Wow.
And
Wow.
let me go back to birth. You made all the eggs that you were going to have when you were about 20 weeks as a fetus in your mom. That's all
Wow.
you were going to get. And from that time till the time of menopause, you lose eggs without ever making them again. And oh, by the way, your eggs are that old. So
Hmm.
the idea behind freezing eggs in women is that you stop and you hold in place that fertility at whatever that peak is, so that then when you want to go and use them 10 years down the road or 5 years down the road, you're still working with eggs that were 5 or 10 years younger, right?
Wow.
Because we
Yeah.
know that a higher percentage of them are going to be normal. So let's talk about normal, right? So if you're making embryos, whether you make them through IVF or they're in your uterus, doesn't really matter. Okay. If you're making embryos under the age of 35, probably about 60 to 70% of them are going to be genetically normal.
Hmm.
Right. And most miscarriage and non-pregnancy is because our bodies just were unable to make a genetically normal pregnancy between the egg and the sperm. Right.
Right.
So by the time you hit 35, you're down to about 50%. Right. By the
Hmm.
time you hit 38, you're down to about 30%. By the time you hit 40, you're down to about 17%. And
Wow.
almost all of that, with rare exception, is an egg issue.
Hmm.
Okay. It's not that sperm doesn't matter. Believe me, there are times in which we can see very abnormal sperm. I have a patient now, we're using sperm from a situation where he was on life support at the time. And before he passed, we were able to get a sperm, and his parents have made the decision to have kids. Okay, guess what? There's a lot of abnormal sperm in there, right? Because
Wow.
that was
Hmm.
a very stressed and extreme situation that sperm was
Exactly.
under. But 9 times out of 10, we're really trying to overcome the egg situation because we have a lot of sperm to work with, right?
Mm.
And so the sooner you can think about having your children and facilitate a way to freeze that in time, whether it's because you actually had the kids or because you froze the embryos or because you froze the eggs or because you started treatment, the easier it's going to be for you to conceive, right?
Wow. Yeah. It's so interesting that you're talking about this because we were talking about a few things before we
Yeah.
started the podcast, and we were talking about donor eggs.
Hmm.
And one of the conversations that happened with me when I first started on my journey to have a little one was my doctor who literally had said, you could get a donor egg, but it's going to be really hard for you because you're Black, your husband's Black. And in our area, it's basically all the eggs are from white people. You might have a couple of biracial people, but your baby's not going to like look like you. And you might need to go to Seattle to actually get an egg donor that is Black. And I was like, this is the first time that I have ever heard this in my entire life. So again, I'm 25, trying to plan a family. This conversation gets thrown out, and I'm like, what in the world?
With all
I'm
due
like, what in
respect,
the world? I am not getting the egg from somebody else. That is someone else's child. I'm not doing that. I'm like, there was no real conversation or a lead up to that. And so I was talking to Dr. Danielle about this. And if you want to just share a little bit about what we were talking
I'm
about
good. I'd
as
love
far
to.
as women in infertility and women of color and egg donors.
the first thing is, I just, with all due respect to your physician, I don't know how you lead with 25 needing an egg donor. I don't even know how you get there, right? There are definitely people who have premature ovarian failure and they will need an egg donor even at age 25. It just doesn't feel like that's what you presented with, and so I'm not sure I have a good answer for how you got there that quickly.
Yeah.
That notwithstanding, one of the conversations that we were having, and one of my passions, is that we do not have enough diversity in our egg donor pool.
Hmm.
There have been a variety of, and now I want to speak specifically to the women of color that are on this podcast. There have been a variety of scenarios that have led to the belief that women of color either won't use an egg donor, don't have the resources to do an egg donor IVF cycle or a gestational surrogate and their surrogacy cycle, and therefore the agencies or the clinics have not gone the extra mile to identify women of color who want to be an egg donor. So by the way, if you're out there and you're a woman of color and you want to be an egg donor, please reach out to me, because we are building our database. It's so important. If you have a friend who you think would be a good candidate and wants to do it, please reach out to us.
Yes.
It's important. The comment that physician made is also troubling to me, because I will tell you that 90% of the egg donors that we work with don't live in the area that we are in. They get their monitoring done someplace else. They come in for a retrieval and they leave. Or we go through a cycle with them, freeze their eggs, and we keep them on site. So the idea that there was not any effort put into helping you find what you needed. I'm also laughing at Seattle, because Seattle's a lot like San Francisco, and that's not where your African-American egg donor is coming from anyway, but a different conversation. But the idea that there was not somebody putting effort into helping you identify that person is concerning, right? And it's very similar in the Hispanic population. We do not have a lot of Hispanic donors. We do not have a lot of, we actually have a larger population of families that would like to use an egg donor, but it's the same scenario. Folks have not been willing to, sort of go out and ensure that their agencies are, really diverse, right? And we know it can be done. It's just people haven't taken the time. So this is one of my passions. So again, if you want to be an egg donor, please reach out.
Oh, I love that you brought this up, because it was the first time that I had ever heard why, some of the whys and what makes it so hard. And so what do you feel are the biggest challenges for women of color to seek help when it pertains to infertility?
There are a couple. I mean, I think culturally we don't talk about fertility very much. I am a fertility doctor, and my mother still maintains that, if I just waited long enough, it would have been fine, because there's no fertility issues in our family. And I'm like, you do know I do this for a living, right? Like sometimes I have to remind anyway. So I don't think culturally it's something that we talk about, right? We just sort of, we chalk it up to your statement earlier. It's either God's will, or we're going to go to church and pray on it. And you can do all of those things. Just know that there are actually treatments available. Right?
Absolutely.
So I think that's one thing. I think a second thing is when we walk into an office, and I say this both with real agitation, but also with concern. I now talk to women from all over the country because people reach out to me on social media. And the stories that I've heard of folks coming in, asking for help, and completely being almost ignored is I don't even really know what to do with it, because it's just beyond my capacity to think that you go into a physician, you say the things that you're saying to me, and the physician just doesn't do anything.
Yep.
So some of that is because I think, people don't listen to our stories and our history. And the other piece is that there's this assumption that we don't have the resources to do the care. Look, there are a lot of people all over this country, Black, white, Latina, Asian, pick your ethnicity, that don't have resources to do fertility care. Okay.
Yeah.
That's a given, because fertility care is too darn expensive. But let's not make the assumption that there are not African Americans or folks of, Hispanic background or, other backgrounds that wouldn't be able to do the care if somebody even offered it to them.
Right.
So I think we have to do a better job of going in there and feeling comfortable with asking for the care we need. We have to do a better job of leaving a place that isn't offering us the care we need. And that's the other thing that we don't do well, right?
Yeah.
I will say that people in the US in general are, I mean, we have all these little health insurance cards. We walk in and somebody gives us care. Like, that's
Right.
just not how it works. I'm gonna tell you, it doesn't work that way across the board. I've been
Hmm.
both a patient and a provider, and I have to advocate for my kids' care harder for all the same reasons that other women of color are advocating for their care, even though my husband and I are both physicians.
Hmm.
But if you know that you need a certain personality, cultural fit, whatever it is for your care, don't feel like you are bounded by the little area that you live in, right?
Yeah.
Take
Yeah.
take the initiative to work with somebody that is going to meet your needs, whether they are next door or in California, because I promise you that will not be the thing that changes the price point of your care or the because if somebody is not listening to you, you are not getting what you need. And back to the point I
Exactly.
made earlier, the longer it takes you to get the care you need, the more expensive it's going to be, both in terms of finances, emotions, just overall resources, right?
Hmm.
So
Hmm.
just, do it. Jump in.
Yeah, it's so interesting that you're talking about this because now we're in a generation where people are having children a lot later.
Yes.
I remember when my husband and I, we got married, we've been married for 11 years, and a year into our marriage, I stopped using birth control. And I was like, if we get pregnant, we get pregnant, we're married, whatever. But I'll never forget when we actually got married at 25. We were like, we really don't have anything, and we just got kicked off our parents' insurance. Like, it just got real.
Yep.
And we knew like we had to do everything possible, one, to break the cycle of poverty in our family.
Yep.
Where my mom and my dad, they were able to break that cycle, but you have to maintain that for a
Yes.
couple of generations
Generations.
in
Yes.
order for it to
So hard.
actually
Right.
actually sustain. So my husband was like, I'm going to go to school and you're going to go to school, we're going to do everything we possibly can to get into these fields that we love and we're passionate about. We're going to make all these right decisions.
Yeah.
Even I talk about, we talked about not getting pregnant as a teen because you didn't want to be a teen parent. You don't want to get pregnant in college because then you're gonna mess up your college. And then you get married and you're like, okay, let me wait a couple years so we can buy a house,
Right.
get a car and do all these things. And then all of a sudden you're ready to have a child and you're like,
Now it's hard.
now what's happening?
Yeah.
All this time has passed. And it can be frustrating because you're like, you feel like you did everything the right way, and it's now become a huge obstacle for you as you've gone through this journey and you are trying to figure out what's next. We were definitely getting ready to do IVF. We were getting ready to mortgage our home, and because we were like, we want this so bad, and we know that it's going to be harder because now I'm 30, I'm 36. And so
Right.
it just makes such a huge difference hearing and talking with you about having children later. So do you recommend, like, if a person is older, maybe they want to focus on their career, they don't want to have children, to freeze their eggs? Because this was a conversation I actually had with a friend of mine. She was like, I know I'm going to be a parent that's a lot older because I want to finish my doctorate degree in
Yeah.
pharmacy, and I want to finish this. I want to do this. And we all know the sacrifice sometimes women make versus men.
Right.
And she knew that just in her relationship, she would have to make the sacrifice. So,
100%.
what is your thoughts about that?
Sure.
And
So first, I want to just touch back on what you said, and then I will come to this. I agree with you. I think that, and I'm only going to speak to the African American experience because that's the one I know. We are still in a situation where we are generationally, economically, in many cases, a generation behind many of our
mhm,
colleagues that are not, the same, right? I mean, there are lots of people that own homes in San Francisco. We don't, but
mhm,
everybody that we know that owns a home in San Francisco got help from somebody to make that happen, right? And
mhm,
so, yeah, it is definitely a scenario where, at least in the African American community, we are fighting on multiple fronts to be successful and maintain success generationally. I also think that if you, I think that as providers of care for African American patients, and by the way, I do this for all my patients, but certainly for African American patients, we're super sensitive to that. And we are
mhm,
like constantly trying to find ways that we can minimize costs, decrease costs. I don't want anybody to mortgage their home to do IVF. Like, I
mm,
realize it happens, but I
yeah,
don't want anyone to be in that position, right? That's why
mhm,
things like InvaCell are so awesome, because they're less expensive and maybe you don't have to mortgage your home and you can get there,
mhm,
right? So I think that's where it becomes useful to really reach out and branch out and make sure you're getting the care that you need
Yeah.
in the way that you need it. And just because they're bigger doesn't mean that they're going to be able to accommodate that better, right? So I just want
Mm.
to point that out. All right. So in terms of egg freezing and embryo banking, and I'm going to comment on both because if you're a single woman, egg freezing makes a lot of sense. You
Hmm.
could freeze your eggs, keep them, know that you're going to have them to use down the road, and it's a little bit less expensive. It's about half the cost of making an embryo and banking it, and so that might be the right thing if you're a single woman. But if you're a young
Mhm.
married couple, you know, embryo banking, meaning you actually take the full embryo and freeze it after sometimes testing it, may
Mhm.
make more sense because now you know not just that you have numbers of eggs, but that you actually have a genetically normal embryo, right?
Okay.
And so I think depending on where you are in your relationship status, right? You may choose one or the other of those. The Bay Area sees a tremendous amount of that because, of course, every tech company under the sun has offered those benefits. And so,
Mm.
Google, Facebook, Salesforce, all of them, LinkedIn, whatever, those folks have really good access to that sort of care,
Mhm.
and they make use of it. I mean, we
Yeah.
probably do more banking here than virtually anywhere in the country because
Wow.
folks have access to resources to do that.
Mhm.
If you are not in a position where you have access to resources to do that, then you have to get a little creative, right?
Hmm.
So sometimes folks are freezing their eggs and I've seen some places do shared cycles. So maybe they want to be an egg donor, but instead of taking money for that, they'll freeze some of their eggs, or they'll do a cycle of their own eggs and a cycle of donation of eggs. Um,
Mhm.
Make sure that you're okay with donating eggs. Don't just do that to get your eggs frozen if you're not okay with donating eggs. But if you
Yeah.
are, like, there's some access for you, right? Or they are looking at ways that they can, make payments over time so that they can, freeze those eggs and then, pay over some period of time. But yeah, I mean, if you can find a way to freeze your tissue in advance, you should do it, right? You should do it because if you're going to be a doctor or a lawyer or a business person or a whatever, pick your career that takes, an astronaut, whatever, it's going to be years before you're ready to have kids.
Yeah.
And while society has changed in terms of where it wants to have children, biologically, we haven't changed since, hundreds of years, right?
Mhm.
1600s, we have data on that it shows the same curve as the 1900s.
Hmm. Wow.
Yeah.
You know what, you guys? I don't know about y'all, but I have been enjoying this conversation. This has been so good for me. And I think for some people that are going through infertility or have gone through infertility, you need some closure on pieces, and like
Mhm.
you need to have like things answered so that you can kind of close certain chapters of your journey because it impacts you, you
For
think
sure.
that something's being done, you think there's being something said, and those interpretations are all according to what we are or thinking or going through. But when you have somebody like really leading you and talking with you and coaching you through, I absolutely love this. Dr. Lane, you talked about, coaching a lot of people all over
Yeah.
the country. This was huge for me because my next step, a lot of you guys know I left my job. My job was so stressful. I loved my job and I was obsessed with my job and I was good at my job. And I was like, this is what I love doing. I love working with kids. I love working with families. I want to make a difference and an impact in my community. But it came to a point where I had to make a decision about, okay, I have to get to a point because now I'm 35 at the time, and I'm like, I have to make a decision about where I want my family to grow and where I want to be at because now I'm at that point and I have to make this decision. And so, I decided to leave my job. I decided to find a new doctor. I love that you talked about petitioning for a doctor. Right now, COVID has set a lot of people free, meaning like, what, we realize we don't have to go to our local, doctor or our local clinic. We can go somewhere else and we can get the same patient care, if not better, somewhere else. I decided to look in LA and start working with another doctor. And she was phenomenal. She coached me through Zoom and was like, hey, this is what you need to do. She took all these different blood samples that no one else had took. She found out that I was low in vitamin B6, B12.
Mhm.
She found that I was low in my vitamin D. I mean, she was like, did anybody talk to you about this? And I'm like, no. And she was like, okay, we need to get you on something different. We need to get a plan going. Everybody knows I talk about acupuncture a lot. We'll have my acupuncturist on here
Okay.
pretty soon. She talked about vitamin B shots and talked to my doctor out in California about it. And she was like, do the vitamin B shots. Changed my life. Once I even felt a difference in my energy level,
Yep.
everything. And so, saying all of that to get to this point, which is our lives are not mapped out. We may have an idea what we want, and fertility can really put a huge, or infertility can put a huge wrench in our plan, what we're trying to do, and how we're trying to do it. And I love that Dr. Lane, she coaches people all over. And that is something that I want you guys to hear and know, that there are people out there that are passionate about you, about your family, about your life, about your body. And they're out there now. And if you don't feel like you're getting what you need in your area, your local area, the skies are the limit at this point, for you to be able to choose someone that you connect with and will really help you to figure out what the next steps would be.
And to be clear, it's also not a new model in
Hmm.
fertility. And I think that's important, right? Remember earlier
Yeah.
I said donors can be all over the country. Most donors aren't in the place that like if I'm looking for an African American donor, I guarantee you I'm not going to find them in San Francisco. They're just
Wow.
like there just aren't that many young people in San Francisco,
Mhm.
period, right? And so we've always been in a situation where we would send outside monitoring orders to another clinic and have them do the work. Next week, I'm having somebody get an endometrial biopsy done in New Jersey that I've been working on.
Wow.
Right? So, the model's there. It works. I think we did talk about this. You have to be willing to put your money where your mouth is in terms of your care, right?
Yes.
I mean, long ago, I had a friend who is not of color who said to me, buy one less dress, get one less manicure, go on one less fancy dinner, and make sure that the things that you need in your household or in your health are taken care of, right? And
Yes.
it seems very logical, but yet we don't actually commit to that, right?
Mhm.
It's worth it. If having a family is important to you and it's not working and you're not happy with the care you're getting, do something different. Don't keep doing the same
Absolutely.
thing, right? Definition of insanity. Don't do it,
Absolutely.
right?
Absolutely. Oh, you guys, I know we can go on and on, but we are
Right?
getting to the end of our podcast. Dr. Lane, what advice would you, or what's one last piece of advice that you want to give to our listeners before we end our podcast?
I think for anyone who's out there that's either concerned or worried about their fertility or feels like they still don't have all the answers, it's a call to action to please take a step and find a new partner in your fertility journey, right? I don't care if it's like another doctor in the same practice. I don't care if it's a second opinion across the country. I don't really care, but find make sure that the person that's partnering with you to get you through this process is a good fit for you. I mean, I think that's the biggest thing that we all can do. Get out of your comfort zone. Like, don't just stay with somebody because like you've been doing it. If it's not working, shake it up, do something different. This is too important. It's too
Hmm.
important.
Thank you so much. You
You're
guys,
welcome.
don't worry. We will have Dr. Lane's, all her information right below this podcast. You guys, I hope you have enjoyed this. I hope this podcast has sent you so much strength and love, because you guys, you know what? It has done me so good today. I am so grateful. Thank you so much for taking time out of your busy schedule, Dr. Lane.
Oh,
It's
thank
just
you for
been
having us.
so rich. And for those that don't know, please go on LinkedIn. All her social media platforms will be right below. Follow, learn, educate, share. You never know who's going through what. And just that simple video or that simple message or that simple word just gets to that person and it resonates with them and it sets them free. You guys, thank you so much again. I want to thank you for joining me here at the Learning Project. Until next time, sending you strength and love. See you guys soon. Bye.